Welcome to The Explainer. Today, we're doing a clinical deep dive into conjunctivitis, moving well beyond the simple red eye to deconstruct the complex interplay between etiology, diagnosis, and treatment. So here's our roadmap. We'll start with a solid overview of the disease itself, then get into the nitty-gritty of pathogen identification. From there, we'll talk treatment, walk through a case study, and then zoom out to look at public health and the very real clinical risks involved. All right, let's jump right in. We're starting with the disease itself. And look, while it's often brushed off as just a red eye, the clinical picture of conjunctivitis is incredibly varied, and it's all dictated by a whole spectrum of different causes. At its core, yes, the definition is pretty straightforward. It's an inflammation of that conjunctival membrane. But, and this is the fundamental point for everything that follows, it's the specific cause of that inflammation that dictates our entire clinical pathway. Now, this slide really highlights a critical clinical divide. The difference in how these two bacteria present is just stark. On one hand, you've got Chlamydia trachomatis, which usually gives you this smoldering, chronic, low-grade inflammation. But on the other hand, Neisseria gonorrhoeae is a completely different beast. It's hyperacute, it's explosive, and it can chew through a cornea if you don't act fast. This isn't just an infection. It's a true ocular emergency, and we can't get tunnel vision on just those common bacteria. The list of potential culprits is huge, and it's a crucial reminder that a red eye can be the first sign of a much more significant, sometimes systemic disease. We're talking viruses, parasites, even spirochetes. Okay, so with that spectrum of disease in mind, the next critical step is figuring out exactly who the bad actor is. Precise pathogen identification is everything when it comes to effective treatment. The lab follows this really meticulous, multi-step process. It all starts with getting a good sample. Then, that sample gets plated onto specific media, like chocolate agar, which helps coax out those picky organisms like Neisseria. After that, it's into the incubator to let things grow before the real identification work begins. So you really need an integrated approach here. Microscopy, like a gram stain, can give you a quick, preliminary idea of what you're dealing with. But for bugs like Chlamydia and Nonagacocca, the gold standard is a high-sensitivity NAAT. And finally, for organisms with known resistance issues like gonococcus, susceptibility testing isn't just a good idea, it's absolutely non-negotiable. And this is where all that diagnostic legwork really pays off. Once you have a name for the pathogen, you can move away from broad-spectrum guesswork and toward a highly specific, targeted therapeutic strategy. This table lays it out perfectly. Look at the difference in strategy for the two most common STIs causing conjunctivitis in adults. For that aggressive gonococcal infection, you hit it hard and fast with one powerful intramuscular shot of ceftriaxone. Done. For chlamydia, it's a totally different approach, a longer course of oral antibiotics. Now, when we talk about neonates, ophthalmia neonatorum, the entire game changes. Treatment is urgent and it's systemic. And notice the critical difference for gonococcus. We go from a single IM shot in adults to a full 7-day course of IV ceftriaxone. That really tells you how much higher the stakes are in this tiny, vulnerable population. For some of the really devastating infections like fungal or acanthamoeba keratitis, the therapy has to escalate dramatically. We're talking incredibly intensive regimens, sometimes with hourly drops, just to try and save the cornea. And something like ocular syphilis, that's treated as neurosyphilis, meaning aggressive long-term IV antibiotics are a must. Okay, let's take all that information and apply it. We're going to walk through a clinical scenario, focusing specifically on those critical distinctions in neonatal conjunctivitis. This right here is a fantastic clinical pearl. In a newborn, the timing of when symptoms first appear is an incredibly powerful clue. It helps you zero in on the likely pathogen based on its incubation period, and that, in turn, tells you just how worried you need to be. This timeline shows you exactly what I mean. If a baby develops this angry, pus-filled conjunctivitis on day 3, alarm bells for N-gonorrhea should be ringing loud and clear. But if the onset is later, say day 7 or 8, and it's less severe, your suspicion shifts heavily towards C. trachomatis. The timeline tells a story.
So let's do a quick knowledge check. The key takeaways here are 1. The absolute urgency of gonorrhoeae because of its potential to perforate the cornea, and 2. That very specific single-dose IM ceftriaxone protocol for treating it in adults.
All right, managing this condition goes way beyond just treating the patient in front of you. It plugs directly into public health and preventing wider transmission. And this is a really important point for any clinician. Some of the systemic infections that can show up with conjunctivitis, like measles or invasive group A strep, are legally notifiable diseases. You have to report them. It's essential for tracking outbreaks and protecting the community. These 4 steps are really the pillars of infection control. It's a mix of universal precautions like obsessive hand washing and using PPE, along with more specific actions like disinfecting surfaces and, crucially, making sure partners get notified for STIs. Finally, we need to talk about the consequences. We have to confront what can happen when conjunctivitis is misdiagnosed or treatment is delayed, because the stakes are incredibly high. This table is pretty sobering. It drives home why getting the right diagnosis is so much more than an academic exercise. Depending on the bug, a simple case of conjunctivitis can spiral into permanent blindness, reactive arthritis, or even disseminated sepsis. The potential outcomes are worlds apart. And the risks just keep going. You have infections like acanthamoeba keratitis, which are notoriously difficult to treat and often end with poor vision. And again, conjunctivitis can be the first clue to a potentially deadly systemic disease like streptococcal toxic shock or neurosyphilis. You have to recognize it. Which really leaves us with this final question to think about. Considering that it can be a sign of a vision-threatening or even life-threatening disease, should we be approaching every case of red eye with a much higher index of suspicion? Because as we've seen, the clinical stakes can be far, far higher than they might first appear.